Without further ado, our first lecture today is brought to us by Dr. Alta DeRoo. Dr. DeRoo is an obstetrician gynecologist practicing in Culpeper, Virginia. She received her medical degree from the University of Florida College of Medicine and completed her residency at Narval Medical Center. Dr. DeRoo is board certified in obstetrics and gynecology as well as addiction medicine. Good morning, Dr. DeRoo. We're excited for your lecture, Smack, Dope, PercoPops, and Chiclets. Cute names, serious disease.
All right, good morning. Yeah, so I'm hoping that this the title was a eye catcher, and we've gotten some people to attend this morning. So if anybody recognizes those names, those are all names that we would use for different forms of opioids. So Chiclets would be little squares of fentanyl, and PercoPops are actually Percocet lollipops that can be given to patients, and they're all part of an opioid use disorder. So we're going to be talking about opioid use disorder in pregnancy today. I was previously in Culpeper, Virginia, and I was working with the University of Virginia, and now I'm the medical director of the Betty Ford Center, our residential treatment facility here in Southern California, and we have two outpatient sites in San Diego and Los Angeles. So I still practice OBGYN and addiction medicine, and I like it when I can bring treatment to both of these populations where those two intersect. So I have no financial disclosures or conflicts of interest to report. Our objectives today, I wanted to take a look at Georgia's status within the opioid crisis so I could bring it home to you and let you know what I found through my research. Understand the standard of care for the treatment of opioid use disorder in pregnancy, and learn about the medications for opioid use disorder, specifically methadone, buprenorphine naloxone, which you may not know the trade name is Suboxone, or naltrexone, both the PO form and the injectable form, also known as Vivitrol. Learn the intrapartum management of the patient with opioid use disorder while they're in labor, and learn the postpartum management for the patient with opioid use disorder. And that's when we're going to touch on some pain control, which is a very popular interest of patients. We have providers. So when we take a look at Georgia's history of opioid use disorder, we see that just like with the rest of the nation, in 2001, we started having an increase in the drug overdose deaths. This is a nice comparison of drug overdose deaths compared to motor vehicle crashes. So we see here that in 2001, in yellow, we have the motor vehicle crashes markedly outnumbering the drug overdose deaths. But from 2001 to 2015, we can quickly see that the overdose deaths outpaced the motor vehicle crashes. And so we all learned in medical school that number one reason for unintentional death would be motor vehicle accidents. But now we see that overdoses from drugs have now outpaced them. This data was from 2015. That's the latest data that they have in this type of report. But I can tell you that this is still the trend. And in many other states, Georgia's not an outlier. So in many other states also, drug overdoses now outpace motor vehicle accidents. This is the latest data from Georgia's Department of Health. And even though it stops in May of 2021, this was published in June. And with this being August, this is their most recent data here. So you can see a marked difference with COVID and the increase in drug overdoses. So we see that for 2018 and 2019, pretty steady. The green is 2020, where we see an increase in the drug overdose emergency department visits. And then you see that in 2021, the increase all the way up to 30% of the emergency room visits were opioid involved drug overdoses. So this is very taxing on the emergency room personnel. But when I put myself in the position of what it's like to maybe be on call when you and I are on call as OBGYNs, and we may be going down to the ED, to the emergency department, to treat a pregnant woman with opioid use disorder or to treat a possible overdose. So these are specific heroin involved overdoses in the emergency department in May, and specific to heroin. So the other one were opioids, so that could be lots of things: fentanyl, Percocet, Dilaudid, any of those things. But this is specifically heroin involved, and we see, again, 2019 markedly higher than in, 2020 bigger than 2018-19, and then 2021, again, we were seeing the effects of COVID here. Now, this is specifically state by state, where we see around here is the increase in overdose ED visits. So if you can see your region here, you can see how there's been an increase since December 2020. So again, we see a lot of effects from COVID. I want to bring your attention over here to the right, which is actually the neonatal abstinence syndrome that was reported within these parts of Georgia. So we see here a little more dense up here in the northeast part of the state, southeast, and here in the southwest. And so I bring this part to your attention right here because the neonatal abstinence syndrome became reportable in Georgia in 2016. And the 2017 incidence rates of NAS or neonatal opioid withdrawal syndrome NOWS in Georgia was 3.2 cases per 1,000 hospitals in that most recent data available. Now, there isn't published data available for me to access since 2017. Now, I'm thinking that, the 3.4 cases, this is lower than the national average of 7, but I'm wondering if it was maybe underreported, because this is a new thing that's coming up. Not a lot of hospitals are still yet used to reporting their neonatal abstinence syndrome. So it's reportable much like you would have HIV reportable in a hospital. And it's difficult for some of us to get used to because we haven't reported this in the past, but it really helps states track your neonatal abstinence syndrome. So in Georgia, this became a reportable condition, a notifiable condition in January 1st in 2016. And it talks about having to report the toxicology, including any positive for opioids, benzodiazepines, or barbiturates for any infant less than 20 days old. And any positive results for all substances should be reported. So kudos if you guys are doing it. It really helps the state determine where the needs are for the hospital. So how can we help our patients when they come in? When a pregnant patient comes into the clinic, you're the OB there that day, and she shares with you, or you suspect, that there may be an opioid use disorder. We're going to talk today about how we can screen for these patients, how we can educate them, how we're going to treat them, talk to you about intrapart management, and some pain control. And most of these suggestions are also going to come from the ACOG committee opinion from 2017. It replaced the committee opinion in 2012. So even though the suggestions come from the committee opinion, I'm going to give you the most recent data and the most recent research. Again, I'm practicing as both an OBGYN and an addiction medicine physician. And so when I put this presentation together, I thought, what would I need to know if I were an OBGYN just still in the clinic, not practicing addiction, or if I was trying to manage a patient with opioid use disorder who happened to be on any of these medications or still using opioids. So that's where my perspective comes when preparing for this. So when a patient becomes pregnant while using opioids, their intention often isn't a planned pregnancy. And we see that in general, 50% of pregnancies are unplanned, but up to 70% of patients with an active opioid use disorder are not planned. And one of the reasons is because their menstrual cycles are very off. Not many of them are using birth control. And there's a big dysregulation in their menstrual cycle. So women with substance use disorders often experience dysregulation of their menstrual cycle. And this is because the chronic opioid use alters dopamine and prolactin levels in the hypothalamic pituitary axis, leading to amenorrhea and unpredictable cycles. It also prevents GnRH from releasing FSH and LH, and so they get an amenorrhea, and again, they're unsure when they're ovulating. And so the menstrual cycle alterations can lead to unplanned and often unrecognized pregnancies with delayed initiation to prenatal care. It would not be uncommon for a patient to come into you who is 22, 24, 28 weeks pregnant because they honestly didn't know that they're pregnant. So one of the ways that we can screen our patients for opioid use disorder is by using a tool such as this. So this is a copyrighted tool. We're familiar with the screening for the 4 Ps if you've used that in the past. So this is the 4 Ps plus. And it's important because each of these Ps are significant in a patient's history with an opioid use disorder. So parents, we know that there's a highly genetic component to addiction. So did any of your parents have a problem with alcohol or using drugs? The next one is partner. And I find this very relevant because when I take a history and physical for a lot of pregnant women that I'm treating, I find that when I ask them how they started, it was often a partner that they started with. It was with a boyfriend, or that boyfriend became then their husband, or it was the father of their baby. And that's how they started using. So it's really important to ask about the partner having any substance use. Also, in the past, have you had any difficulties in your life due to alcohol, drugs, or other prescription medications? And then pregnancy. In the month before you knew you were pregnant, how many cigarettes did you smoke? How much alcohol you drink? How much marijuana did you smoke? So what this does is this allows us to gauge risk. These are high risk behaviors. So this is a nice screening tool that you could implement with nursing staff when they first come in, or perhaps the patient can fill it out on their own, but it's a real conversation starter with patients. So screening is a big part of identifying this disease and having patients open up about it. So talking about medications for opioid use disorder, both ACOG and ACAM, the American Society of Addiction Medicine, both endorse treatment with an opioid agonist, an opioid replacement medication. Specifically, they speak about methadone or buprenorphine. Buprenorphine is the active ingredient in Subutex and also Suboxone. So we're less, when we say we, I mean us, OBGYNs, we're less in favor from withdrawal from opioids during
Recording
pregnancy.
stopped.
So there were a couple case reports in 1970s that did talk about moms withdrawing from opioids, withdrawing from heroin, and they had some IUFDs, so babies expired in utero. And then the thought going forward was don't ever withdraw a woman in pregnancy. That was a long time ago, again, only a few case reports. And there have been several studies since then that show that if mom were to withdraw from opioids, it's not a life-threatening condition to baby. The biggest problem, though, is that when they withdraw, baby, yes, feels a little stressed. We do have evidence to show that there's increased cortisol in some studies. But the biggest risk is mom relapsing. So we're less in favor of withdrawal during with opioids during pregnancy, and we would rather have moms seek some type of medications for opioid use disorder, such as methadone or buprenorphine. Another way that you can also treat an opioid use disorder that we're going to talk about, brand new research, is treatment with an antagonist, such as naltrexone. All right, so let's move on and talk about methadone. So methadone you may have heard of as either in an OTP, an opioid treatment facility, or for pain control. So methadone was originally approved to treat opioid use disorder a long time ago in the 1950s, and it was marketed under a trade name of Dolafine. And you may still hear it called Dolafine for patients who are prescribed it. So we have safety data going all the way back to the 1950s. Currently, though, methadone is only prescribed for opioid use disorder at a methadone clinic, at an opioid treatment facility. And this is a federally controlled or guided facility where it's very structured, has therapists there, has counselors, has a nurse practitioner or a physician to counsel about opioid use disorder, and they're dispensed. It's a visualized dispensing of the medication in a liquid form that patients were to take every day. So it's sort of a one-stop shop for patients to come in with an opioid use disorder. They get their medicine, and then they also get counseling or any type of guidance that they need. And so it's a highly structured environment. One thing that I would say about methadone that's really important for us to know as providers for women with opioid use disorder is that methadone is a full agonist at the mu receptor. So the mu receptor is where all the opioids act in the body. That's where a lot of your pain relief happens. So we're focused on the mu opioid receptor. But methadone acts as a full agonist. So when you take methadone, you're going to get your receptor activation just like you were taking fentanyl or Dilaudid or any other opioid, because it's a full agonist. And so like morphine, like Percocet, hydromorphone, fentanyl. One thing to know also about methadone, besides it being a full agonist, is that it prolongs the QT interval. And so when it prolongs the QT interval, if we have patients taking other medications, like we give Phenergan, right? We give Phenergan all the time for patients who are nauseous in pregnancy. Well, that also prolongs the QT interval. So if we think we have to take into consideration all the other medications that a woman may be taking when she's pregnant. So it prolongs the QT interval, and it also has a high overdose risk, because if you take a lot of methadone and it being a full agonist, you can also precipitate an overdose. So not to scare you from methadone, but methadone does have its risks. Now there's buprenorphine. Buprenorphine was approved to treat opioid use disorder in 2002. This is safe in pregnancy, and it can be prescribed by any provider now that President Biden has relaxed some of the regulations. Any of us who prescribe opioids or any of us with an XDEA can prescribe up to 30 patients. Previously, you needed to attend a certain training. And if you want, also currently, if you want to go above 30 patients, you have to apply for an XDEA waiver. And if you're interested in that, let me know. I can hook you up with that later. This is a daily dosing also. But the one thing that's different about buprenorphine compared to methadone, it's that it's a partial agonist. It's a partial agonist. So because it only partially activates the receptor, you're not going to get those risks of overdose. Very low risk of overdose with buprenorphine. And the toxicology reports show that the people who do overdose on buprenorphine are because they're combining them with other drugs or medications, specifically benzodiazepines. So the nice thing about buprenorphine is that it has a ceiling effect. So this is a really important graph here that I want to spend a little bit of time on, because it's important for us as physicians or prescribers to understand how these two medicines work. But my big focus is to be on buprenorphine, because these are the things that we can prescribe. We can prescribe buprenorphine monoproduct known as Subutex, or we can prescribe Suboxone. And so over here on the y-axis would be receptor activity, and then over here on the x-axis, we see the amount of medication. And so if we're using methadone, so this is going to be methadone right here. This is going to be your methadone line. If you use a lot of methadone over a while, you're going to get all of your receptors activated. And when you get all of your receptors activated with a full agonist opioid, the things that come along with that are respiratory depression, hypotension, somnolence, and overdose. This is going to happen if somebody gets too much methadone, too much fentanyl, too much Dilaudid, right? So this is going to be your full agonist medication. Your partial agonist, the buprenorphine, has a ceiling effect. And this was what makes it safe for us to prescribe from the office. And so if you were to prescribe buprenorphine, even at a high amount, you see that the patient has a ceiling effect, and the patient doesn't have these symptoms right here of the respiratory depression, somnolence, overdose. Because even if you prescribe, or a patient were to take a lot of buprenorphine, and sometimes up to 64 milligrams, that's not a dose. I'm just saying if somebody were to take all of their medication at once, you would still get this partial agonist effect where it's not going to activate all the receptors. So in that way, we can be reassured that the patient has a very low risk of overdose. So methadone and buprenorphine are both suggested in pregnancy to be given to a patient with opioid use disorder. And so which one, we often think to ourselves, well, which one is better? If I have to talk to a patient about methadone versus buprenorphine, how do I counsel them? Well, there was an excellent study done out of University of North Carolina, which involved many sites, and it looked exactly at this. It looked at babies who were exposed to methadone or buprenorphine in utero. And it was a double-blinded, double-dummy, flexible dosing, randomized controlled trial at at 8 international sites. And the primary outcomes were the number of neonates requiring treatment with neonatal abstinence syndrome, the peak NAS score, and the total amount of morphine needed to treat NAS, and the length of hospital stay for these neonates. And what we found, or what they found, was that comparing methadone to buprenorphine, if a baby was exposed to methadone, so if a mom was taking methadone in pregnancy, then the baby required more morphine to treat the symptoms of NAS. Whereas if baby was exposed to buprenorphine in utero, the baby required less morphine to treat the neonatal abstinence syndrome. Regarding mean hospital stay, if a baby was exposed to methadone, the baby's average stay back in 2010 was about 17 days. However, if the baby was exposed to buprenorphine in utero, we see that the length of hospital stay was much shorter, around 9 to 10 days. Regarding the mean duration of NAS treatment, meaning how long did this baby need to be treated for NAS symptoms, we see that with methadone, that baby required treatment for longer, up to 10 days, to whereas if the baby was exposed to buprenorphine, they needed less, there was a less duration of NAS treatment. So from these primary outcomes, we can see that if a baby was exposed to buprenorphine, they needed less morphine to treat the NAS symptoms. They had a shorter length of hospital stay, and they were treated for a shorter duration for their NAS symptoms. So when I take a look at the outcomes of this study, and there are a lot of other studies that also validate this, that buprenorphine, one isn't better than the other, but we sort of have to think of it this way, that buprenorphine seems to be a little kinder and gentler regarding babies' withdrawal symptoms or neonatal abstinence syndrome symptoms. So in this respect, buprenorphine is a little gentler to baby when baby's withdrawing. And so one question often comes up, well, if I want to treat them with buprenorphine, and we looked at buprenorphine versus methadone, and I can prescribe buprenorphine from my office and with my DEA, should I prescribe buprenorphine, otherwise known as Subutex, or should I prescribe buprenorphine naloxone? Because we hear Suboxone all the time around, right? So a while back, a lot of the literature, books that you're probably still reading, say that the standard is the mono product, which is Subutex. And for a while, everybody was prescribing just the mono product. Well, it's very abusable because it doesn't have any naloxone in it. Naloxone was put in it, another long story, but naloxone, if injected, will make a person withdraw. And so we always prescribe Suboxone instead of Subutex for just the general population. Well, we started saying, is there anything bad in Suboxone that we can't prescribe it? And we found that when moms were given Suboxone in pregnancy, that actually there were no adverse fetal outcomes. And so there are plenty of studies now that support the use of Suboxone in pregnancy, and we're finding that the naloxone component is not harmful to baby, and there are now no adverse outcomes. And so these are just several studies that you can cite, but this is one of these situations where the research and the data will eventually catch up with the textbooks and the teaching. One other piece of information that I wanted you to know about, and this is sort of exciting, that naltrexone had not really been studied extensively in pregnancy. And in this study, which was just published in 2020, we see a randomized controlled study with patients using methadone or buprenorphine versus moms who were randomized taking PO naltrexone. And this was 121 patients with naltrexone, the PO form, and 109 patients were using methadone and buprenorphine. And then they took a look at the NAS symptoms with babies. And they found that the newborns, the rate of NAS in neonates was significantly lower in the naltrexone MAT group. So only 8% had any NAS symptoms versus 75% had withdrawal symptoms from methadone and buprenorphine in utero. So that's really great data. So before we weren't even sure if naltrexone is safe. And we have this study showing that babies have a lower risk of NAS. And I would say here too, that there were no adverse outcomes with the neonates, that there were no issues with babies exposed to naltrexone. There were no complications. And there were also no fetal heart rate monitor tracing changes when moms switched from methadone and buprenorphine or started naltrexone, which is really great information. So this is cutting edge stuff that I think that you probably will be seeing in the future, that this may be an option. So quickly, I wanted to go over things that we should keep in mind when we have a patient in labor. So let's say you have a patient who comes in labor and they already are in some type of maintenance, or they're in recovery and they're taking methadone or buprenorphine or Suboxone or Subutex. All right, the things that we want to avoid during labor would be nalbuphine and butorphanol. All right, so Stadol and Nubane. We would want to avoid these. The reason is that these are mixed agonist antagonists. So the antagonist part of these medications will actually displace methadone or buprenorphine from the receptor, and it'll put the patient into withdrawal. So if we have a patient come in and they're maintained on methadone or buprenorphine, we want to be careful not to give them Stadol or Nubane, all right? And so this is a patient who was actually maintained on methadone, and she requested pain medication. She didn't have an epidural, she was in pain, she was maintained on methadone, and so the provider gave her nalbuphine, 10 milligrams IV, and then the patient quickly became agitated, crying, complaining of severe abdominal cramping, muscle cramps, cold, was shaking, tremulous, very much like opioid withdrawal. And the vital signs were not recorded. Her fundus was soft, and no other problems physically that they could find other than the patient was not feeling well. But then we see in the fetal heart rate tracing, baby didn't like this at all, right? So baby became tachycardic, no D cells though. So this was not hurting baby. So baby became very tachycardic. Mom's withdrawing, she's very excited, and baby is going to feel the same way. So then the fetal tachycardia continued for about 45 minutes. There was discussion, they had an epiphany, realized what had happened, and then they gave the patient IV morphine, which again is going to be that full agonist. And so the full agonist medication reactivated those opioid receptors, made the mom comfortable again, and the baby's heart rate came back down. Again, no D cells, no discouraging things from baby, but we want to avoid those two things, the Nubane and the Stadol. So intrapartum management, we want to continue the methadone and the buprenorphine. Don't stop that. Keep that going as a maintenance medication. Highly encourage the epidural. It helps the patient with the pain management. Discuss the expectations of possibly keeping the epidural in for after the period of a vaginal delivery, to allow for pain management, so you don't have to give opioids. For a vaginal delivery, we want to encourage Toradol, IV Tylenol, gabapentin. A cesarean, consider a PCA. You're going to need something like fentanyl or Dilaudid to override the strong affinity for the methadone or the buprenorphine. You can switch to the PO full agonist, short acting, like Percocet. Please use NSAIDs and Tylenol as much as you can. And if you have to send them home with an opioid and somebody's in recovery, please send them home with just a small bottle, maybe 6 or 9 tablets. And then we want to really encourage breastfeeding. So breastfeeding reduces the risk of neonatal abstinence syndrome and promotes the bonding with baby. A lot of people think that, well, gosh, the reason that it reduces NAS symptoms is because they get the buprenorphine or they get the methadone through the breast milk. It is just a minuscule amount of medicine that gets into that breast milk, and it's not enough to even control those NAS symptoms. The reason why breastfeeding is so good for NAS symptoms is because the baby is soothed. The baby is soothed without medications. And so that's the nicest thing that we can do for a baby to reduce NAS symptoms with a non-pharmacologic approach, all right? So one public service message that I would have before we close and start taking questions is that it's really important for us as OBGYNs to not be using pejorative or judgmental language when we're treating our patients with opioid use disorder. And so I have heard a lot, not with OBGYNs, with everybody, who say, you know, will my baby be born addicted, or these babies are addicted to opioids. Actually, the babies are not addicted to opioids. They're just passengers in the mom who have become passively dependent on opioids. And there's an easy way to wean them from opioids. And so when we say, or when we endorse, or when we hear patients say that this baby is addicted, this is stigmatizing for mom, and it will lower her self-esteem and possibly decrease her engagement with the baby. And so we just want to want to avoid the label of being born addicted and just say baby may be dependent on opioids, which is actually the case. Baby does not meet the DSM-5 criteria for opioid use disorder. So that's one of the things that we can do just by changing our language as being an OBGYN. And just with the time allotted, I'm going to go ahead and close right now and take any questions. So it looks like we have about 8 minutes for questions.
Dr. DeRoo, that was fabulous. Thank you. I learned a lot with your talk, and I appreciate you bringing it to us. And I also appreciate your grace in correcting us today on your new job placement and situation. They are so fortunate to have you. It's my personal opinion that if every specialist also had OBGYN as their skill set, the world would be a better place. I invite anyone to turn your camera on today and mute yourself. We've got plenty of time for questions. You can conversely use your chat box, and we're watching it and monitoring it here.
Okay.
All righty. Dr. Castleberry, would you like to unmute and turn your camera on and share your question with group?
Sure, I'm not turning my camera on though.
That's fine.
Thank you so much. That was a wonderful presentation. Really, really useful in a lot of parts of our state. I wanted to know, what are your thoughts on Duramorph and epidurals and spinals? And secondly, especially in the case of C-section, when's the best time to resume the methadone or buprenorphine, since we're going to be giving them, you know, something for the acute pain, incisional pain anyway?
Right. Dr. Castleberry, great questions. I'm so glad you asked them. So the Duramorph, I highly recommend it just because it gives us a longer time for analgesia. So I strongly recommend it. I've used it in my patients. And with the methadone and the buprenorphine, you were asking when to resume it. Don't stop it. And I know that may be different from what some people have been taught. Don't stop their methadone or buprenorphine. What you're going to want to do is give short-acting full agonists like Percocet or Vicodin on top of that. So don't stop their methadone or buprenorphine. You keep that going in both a vaginal or a C-section. That may be new.
Okay, thank you so much.
For you, but that's something that we've been teaching for years.
Okay, thanks so much.
You're welcome.
Any additional questions?
Hey, this is Kathy
I don't
Bonk.
think
What
I see
about,
any.
I can't show my picture either, but what about polypharmacy people? All the marijuana laying around and
Right. Yeah, so you sound like somebody who's asking a question from reality, because nobody comes in with just an opioid use disorder. Rarely will you see somebody using just heroin. I could talk all day on methamphetamines, alcohol, marijuana. This was specifically, the time allotted was only to discuss opioid use disorder, but the marijuana, you're going to see that in many parts of the patient population. We know that it affects baby's brain developmentally as babies start, getting older. But the marijuana doesn't have any impact on the opioid use disorder or the treatment with methadone or buprenorphine, and it's not going to interrupt your pain control. The other, that's really broad. The methamphetamines, carry different risks with them. We don't have a medication for those yet. Only opioid use disorder, we pretty much have a medication. But yeah, people come in with polypharmacy all the time. Probably the biggest one you're going to see are benzos and marijuana.
Dr. DeRoo, I just wanted to give you one of the chat comments. One of our physicians said they can't wait to share this talk with their residents, and I share that feeling.
Great.
I think it's terrific content.
Well, it's wonderful that I hear you guys saying this, because here at Betty Ford, we are very much interested in sharing this knowledge with everybody. We also have a partnership with Georgia Alliance for Addiction. So if anybody's ever interested in having me out or one of us out to talk to your residents or in medical school, we'd be very happy to do that. We do it frequently.
Thank you so much. I think you just booked yourself a flight, the next one
That's
out.
fine. I love Georgia. I love Georgia. I hope I can be with you guys next year in person.
Oh, well, we will keep that in mind definitely, and we'll have you out. We would ask if you would be so gracious as to share both your references and a link to the Georgia Alliance that you just referenced. I think we'd be so happy.
Yep, absolutely. The references
Dr.
are on
Roy-
the slide. Well, do you mean my personal data? But the references are on the slide.
Okay. The Georgia Alliance link would be helpful, and we can reach out to you and get that. One final question, Dr. Royak, would you like to unmute yourself and share with the group?
Yes, thank you. Excellent talk this morning. So recently I had a patient that was taking 160 milligrams of methadone a day, and I actually asked one of our anesthesiologists about the appropriateness of continuing short-acting agonists, and he echoed the same thing. He said, continue with the methadone, do not change that, and give the patient a few days worth of Percocet. So my question to you is this, when you see this patient for the first time, most of the time you look at the partner and perhaps it's obvious that that person is in a similar situation, but I have recently seen a number of partners who are not using opioids. And my question is, this seems to be a better position for the patient to be in. And do these relationships tend to last longer than the relationships in which they're both using opioids?
You bring up such a great point. And I'm glad that you brought that, because I see this all the time too. So even though this is an observation, I do find that the women who are married to men who maybe are in recovery or not using opioids, they usually do better in recovery. It's easier for them to stop. We can look at it just like somebody is smoking tobacco, right? It's very difficult to quit tobacco when your partner is smoking. So if we find that there is a sober partner or somebody who's not using, when the patient can start to titrate off of their methadone, their family and their spouse is a huge supporter. And I do find, I'll have to say anecdotally right now, that they do very well. They do very well when they have that strong supportive partner. Even in residential treatment, which I'm here now, I see women all the time who come in and it's their husbands who have gotten them into treatment, or their boyfriends. I don't know of any data, but I will look into that, because that's a great question. I'm sure there's got to be some data on there.
Thank you very much.
Yeah.
Any more questions? I don't see anything in the chat box. And if there are no further questions, again, Dr. DeRoo, thank you so much for participating. And I quite enjoyed your content.
It was a pleasure. Thank you so much for having me.